Hello, everybody. I know you love these shows when we do split screen with Dr. Mike. Dr. Mike knows everything. Is that right, Dr. Mike?
No. It's not even close.
Not too much pressure. But one of the things I love to do with my constituency is connect you with the best and the brightest cutting edge scientists, doctors, professionals. And one of the complaints I hear all the time when anybody goes to the doctor is there's never enough time. I have a doctor friend in Canada, and their medicine is different from ours. He sees 70 patients a day. And we said to him, how do you do that? He said, well, we say things like, what you have is going around. So the doctor's time is limited, in the offices, but that's what's so great about doing these shows with Dr. Mike. You get to have the opportunity to ask him the questions that are on your mind. And today we're going to talk about the heart, because the heart is, in fact, the biggest killer of women. And welcome, Dr. Mike.
Well, thank you so much, Suzanne. It is always so much fun to do this.
Yeah. Is the heart also the biggest killer of men?
Yeah, it's our number one killer, men or women,
right,
across the board. And what's interesting, we have spent billions and billions of dollars in statin research, billions and billions of dollars on statin medications and some other medications, and we haven't done anything to reverse that trend. It still is our number one killer, and it makes you wonder, like, what are we doing, or what are we missing? Like, with all that focus on cholesterol, we forgot that there's several other risk factors, right? And we're not addressing those appropriately in people. So I'm glad we can talk about that a little bit today.
Right.
Because that's where you're going to see a reversal in this is by looking at heart disease in its complete picture, not just one thing like cholesterol.
Well, from the books that I write, what I'm picking up from doctors is that cholesterol isn't the issue that everybody thought it was. The issue is inflammation.
Yeah.
And that's what the doctors in the know are doing is testing for inflammation. That would be taking the highly sensitive CRP test, C-reactive protein, right? That
would be one of them. As a matter of fact, I think there's several that we can talk about now. Yeah, what you're hitting on is really probably the thing that sets up heart disease, right? So when you have chronic inflammation, that type of inflammatory state is kind of like it attacks your arteries, right? It gets right into that inside of the artery and makes them inflamed. It's called intravascular inflammation, and that's where you start seeing the plaques develop, and you start seeing weird things happen in the arteries. And so I think you're really onto something there. I've told you this before, and I think you agree. Chronic inflammation is the common denominator in all age-related disorders, right?
Absolutely.
And at the top of that list is cardiovascular disease. And so I would encourage everybody that's watching right now, you should know your inflammatory markers and where you're at with those as much as you know where your bad cholesterol is, right?
So for someone who says, well, how do I know my inflammatory markers? What tests do they take?
Yeah, so you mentioned one, right? That's the highly sensitive or highly specific CRP. That's kind of the go-to, but there's many other ones. I would also suggest something called fibrinogen. This is a marker of intravascular inflammation and how prone you are to making clots. So we want to make sure that's on the low side. Homocysteine, that's another inflammatory marker that can cause that intravascular inflammation. This is a big one that I bet a lot of people have never even heard of. It's called PLA2. It's phospholipase A2. Have you ever heard of that one, Suzanne?
I have not heard of that one.
Yeah, no, this is the one that drives me kind of crazy because I don't know why conventional cardiologists don't know about it. It has been clearly shown that pretty close to when somebody has a heart attack, that PLA2 number is quite high. And people who have had heart attacks and maybe a week later or a month later after they've had bypass or a stent placed in, if that PLA2 enzyme is high, that's an indication that there might already be blockage again, and they got to go back in and make sure it's clear. It's a powerful enzyme that's a marker of intravascular inflammation, but specifically inflammation within arterial plaques. See, if that number's high, it tells me you got these inflamed plaques, and those are the ones that are prone to rupture, causing acute heart attack. So PLA2 is a number you should know as well.
So if it were me and everybody watching, I would say, write that down, because when you go to your doctor, you forget. Also, homocysteine is interesting to me because I'm Irish. Did you know that? That's happy Irish woman here. But the Irish have high homocysteine levels. And in my family, everybody dies of heart disease. We're hoping to change that paradigm, with these generations. Right. But what is the antidote for high homocysteine? Yeah,
that's great. Well, before we go there, we've learned a lot recently about how high homocysteine actually causes damage and inflammation. Because, for a long time, Suzanne, there were a lot of conventional cardiologists who didn't believe homocysteine was a risk factor. And they wouldn't check it. But now that we understand it more, I think more and more of the conventional cardiologists are ordering this. And then when we have champions of our industry like Dr. Sinatra, who has been a proponent of measuring homocysteine, more and more are doing it. But it's really interesting, and this is a good time for us to talk about anatomy. I know you like anatomy, right? So
I do.
Yeah. When you look at an artery, like you're looking down the artery, right? Like looking down the tube.
Right.
Lining the inside of that artery is a single layer of cells called the endothelium. Each one of those cells is called an endothelial cell. It wasn't that long ago that we were taught arteries are just basically pipes, and the blood went through. That is not true. They are very active organs, and these endothelial cells control a lot of things, but specifically they control the rhythm and the expansion of the artery, and then the relaxing of the artery. When the heart goes thump thump, and your arteries are doing that too, thump thump. That's the endothelial cells. And if they're damaged, you're not regulating that flow very well. And that's where high blood pressure comes in. And that's where you damage the artery more and you can get more plaque. High homocysteine directly damages those endothelial cells. These endothelial cells, they connect together. They grab onto each other. And they hold on with what are called adhesion molecules. And homocysteine has been shown to tear those connections. And so you open up that lining a little bit, and now all that blood and inflammation and immune cells can get inside the artery. And that's the beginning of arterial plaque. Yeah. And so we actually think homocysteine plays a role in the initial stages of developing plaque. We never knew that before. So check your level, make sure it's low. And if it's not, you ask what you can do about it. Here's what I love about natural medicine. Our answers are sometimes so simple, right? Start with some B vitamins.
I was just going to say vitamin B. Yeah. And if it's real high, I remember at one point my homocysteine was real high, and my endocrinologist at that time had me taking daily vitamin B12 complex every day for quite a while. Yeah. So I got it all normalized. But what a great way. Now, I have found recently that you can get the same vitamin B as a liquid that you inject. Do you think it's as effective?
I don't, I've seen that too. I don't think there's enough data to really know. Yeah. You're asking a question about what we call, the science part of this is called the kinetics of a nutrient, how a nutrient gets into your system, how it's delivered to tissue, how it's metabolized, and how it leaves. Yeah. All of that kind of refers to the word kinetics. In the pharmaceutical world, we call it pharmacokinetics. In the supplement world, we call it nutrakinetics. I don't know if we have enough kinetic data looking at those liquid Bs yet. I do know that the injections of any B vitamin works really well, but every day pretty cheap capsules with powder in them work really well for the B vitamins. They're water-based nutrients. They get in pretty easy. I don't think we need to overcomplicate the B vitamins. A simple B complex is good for anybody all the time. But if you have a slightly elevated homocysteine, I'd suggest that. If your level is a little higher than just a slightly elevated, if it's moderately elevated, there's other things. There's trimethylglycine, TMG, which is really good. It's another form of a B vitamin. That's something that I like to use. And then, of course, you could just do high doses of B12. And if you have to, you can do injections. And that brings down that homocysteine nicely.
Yeah. Well, if your homocysteine is high enough to require injections, I will tell you in front, they sting. They sting and burn. And for a while I was giving them to Alan, and he'd actually get mad at me because it would hurt him. So I go, stop being a baby.
Well, I'll tell you what, a little sting now is a lot better than a big blockage in your artery later on. Right?
Totally.
Yeah.
Totally. You know, and you brought up Dr. Sinatra, who has long been a proponent that cholesterol is not the issue. He wrote a book called The Cholesterol Myth. Yep. And there are new ways to take care of the heart. That's why I urge my constituency, even if, you know, you've had your regular cardiologist, listen to what Dr. Mike is saying today, and then ask those questions. If your doctor is not up on that, maybe it's time to look to a new doctor, to find somebody who's more cutting edge. It's your life.
Yeah.
And yes.
You know, it's interesting you're saying this, because I was talking to a friend recently who has some risk factors for cardiovascular disease. And of course, he sees a very conventional cardiologist. And matter of fact, his cardiologist doesn't even like him talking to me, because he knows because every time he sees me, he goes back in and brings in stuff. He's like, stop talking to Dr. Mike. But he was telling me that out of all the advice that this cardiologist, and it's a pretty popular cardiologist here in South Florida, out of all the advice he gives him, he basically just says, take your statin, take your aspirin, and stop eating so much meat, like saturated fat. And you know what's crazy about that? And Dr. Sinatra wrote about that. That it's saturated fat is not really the culprit here. You know what the culprit is in your diet? It's sugar.
Of course it's sugar.
Sugar drives the bad cholesterol higher than any eating saturated fat does. But no one gives that kind of dietary advice, and it drives me crazy because they're just not keeping up with what the current information is showing us about sugar and cholesterol and cardiovascular disease. They're just not keeping up.
And when did we decide that butter was bad? You know, I came across a stat when I was writing this book. Okay. You probably know this, but butter has almost the exact same percentages of saturated fat, monounsaturated fat, and polyunsaturated fat as, are you ready? Breast milk. Mm-hmm. So that means nature wanted to start us out on a high-fat diet. Yeah. You know, the whole don't eat any fat. We gave up fat when that whole flawed study came out with Ansel Keys in 1941, and Dwight Eisenhower had his heart attack. And when we gave up fat, we all got fatter and sicker.
Right, we did.
As we went to pastas and things like that, which is sugar. Yeah. Sugar, you're right on with sugar.
It's the key thing. You know, the whole low fat craze. I mean, that in the 1940s, we had a couple of flawed studies, but from those flawed studies, you know, came this huge movement that really took off in the 70s and 80s. You know, if you remember back then, that's where everything was now fat free.
Margarine, right? Remember margarine?
Margarine, yeah. Let's try to make a man-made fat now that's going to be better. That turned out to be the worst thing you could put in your. Imagine that. Imagine humans messing this up, right? I mean, you know.
And then we got used to the taste of margarine, and everybody liked the taste of margarine better because chemicals are designed to taste.
Yes, I was just going to say, because they designed it that way. There are flavor scientists that figure out how to make these preservatives and these trans fats taste good, and you know what? Taste a little sweeter. See, we like
that's what it was, and everybody loved it, and you use a lot of it because it's not butter, so you just load this stuff in. Yeah. I think those changes that we made were the beginning of the health epidemic that we're experiencing now, where everybody's got something wrong with their stomach, that people have high chemical levels. You call it trichocysteine levels in their blood. There's a way to test for your toxic burden in your body, isn't there, Mike?
Well, there's several different things you can do. First of all, there are more and more companies like Life Extension that we know about coming up with panels that can look at different plastics and toxins. You can do hair analysis with these. You can do urine analysis with them, but it kind of looks at your overall burden. You can also just, you know, so much of this happens in the gut, right? Yep. And so there's now studies coming up being able to look more specifically and diagnose like leaky gut syndrome, and looking also at your small intestinal bacterial overgrowth. There's a bunch of bacteria that can get kind of stuck down there, some of the bad guys, and cause a lot of problems. So we have tests for that as well. So more and more of these heavy metal tests, these toxin tests are becoming more sophisticated. They're becoming more reliable. And I think we should start seeing these move into mainstream, because we know that these things are causing a lot of oxidative stress. And we go back to this now, inflammation in the body. I mean, at the end of the day, that's what a lot of these toxins, whether it's molds, whether it's pesticides, whether it's all these different types of artificial sweeteners, colors, whatever, they ultimately drive inflammation in your body.
And another thing that the body needs cholesterol. Oh, by the way, every cell needs protein, fat, and
Where
carbohydrates.
hormones come from.
Cholesterol. So, there's a question up, and I'll have you answer it. But she asked about statins. My understanding of statins is when you take statins, the plaque you have is the plaque you have. It'll just keep you from making any more. But then there's so many side effects with it, like the muscle wasting and brain fog. And tell me more about statins and your feelings about them.
Yeah. So, I think that they do, I'm an integrative medical doctor, right? I will use whatever I think needs to be done in a variety of things to help somebody. Right. And so I do think, is there a case, is there a certain time when a statin medication might be appropriate? Yeah. If somebody's already had one heart attack and their cholesterol level is sky high, that's the kind of situation where I might put them on a statin to get control over that. But the ultimate goal is to then integrate into that some of the more natural things that we can do that also can help to bring that down. And once you get it nice and controlled, then maybe you start backing off that statin. The goal is to get off the medicine and to be on the food and to be on the supplements. So there are scenarios where I might use a statin to get control over things. But here's what I'm seeing more and more happening. You're talking about people who are low risk or maybe moderate risk. They have slightly elevated cholesterol, and they're given statins like candy now. There's no more diet and exercise talk. Well, that talk was pretty bad from conventional doctors anyways, but there's really no more effort at all. It's just, okay, slight risk, slight elevation. Here's your statin, move on, and, see me in 6 months. Right. And that's inappropriate. That's not practicing medicine. That's practicing pharmacology. Right.
I call it Band-Aid medicine.
Yeah. And it's just not. So there are a lot of cases where statins are not appropriate. And then the last thing about it, I will say, because at the end of the day, statins work, they do drop your cholesterol, but maybe that's the problem. They do it too well, right? I mean, I know people on statins that have their total cholesterol is almost non-detectable. I mean, you can't. How are you going to make hormones? How are your cell membranes going to heal and stay healthy? So I think they've become a go-to drug in many cases where they're not necessary. And I think when they are necessary, they're overdone, knocking these poor patients' cholesterol levels to the point where there's none left. And now they can't make hormones and other fats that are important in their body.
Yeah, Dr. Sinatra's thinking is very much in line with yours. He said to me, I can count on one hand the amount of patients I have on statins. Yeah. He said, usually the reason I'll put someone on a statin is the second component of cholesterol, which is LDL, the so-called bad cholesterol. That my understanding is, and correct me if I'm wrong, is that LDL causes the synapse between cells. It's the little bridge. All the cells talk to one another, so you got to have some way to connect them, and that's made with LDL. He said that when he does resort to a statin, he said, before I do that, I'll try a natural blood thinner like lumbrokinase or nattokinase to get the second component of LDL, which is called capital L, small p, little a down. Yeah. So what is your feeling about LP little a?
Yeah, no, that's okay. So, Suzanne, you actually know more than I think conventional cardiologists out there do, because we've been studying this for a long time. So there's probably a more dangerous marker of arterial plaque than LDL is this thing called lipoprotein little a, or the L, which you just mentioned. Yeah. It's a very atherogenic component of cholesterol that probably is the culprit behind a lot of people having heart attacks, but their LDL levels are normal. Have you heard about that before, right? I think the statistic is something along the lines of like 45, 50% of all heart attacks, these patients have normal cholesterol, but they're not checking everything they should. That's based on that standard test, right? LDL, HDL, triglycerides. That's it. It's not looking at anything else. Lipoprotein little a, LP little a, is not part of that standard test. And it's been my theory for a while. And I've talked to Dr. Sinatra about this, and he agrees that that's probably what's high in a lot of these people, driving those arterial plaques. And statins don't necessarily help LP little a come down.
And I describe LP little a as like little razor blades on the inside of the arteries.
Yeah.
So, but you're right. Very few doctors look at the second component. So what I want for all the people watching today, write this down. Again, when you go to have your blood checked, yes, your HDL, you want to see what that level is. And yes, your LDL, but also tell them you want to know the second component of LDL, which is capital L, small p, little a.
Yeah. LP, lipoprotein.
Yeah,
and it brings up a nice a thing we can talk about, a conversation we can have about what's called advanced cholesterol testing, which is far better than the standard cholesterol test that just about every American adult has had, right? Again, like you just mentioned it's basically HDL, LDL, triglycerides, total cholesterol. Well, those numbers in that test that you get back, they're not actually counting. It's just calculated. And it doesn't really assess your risk. There are people that have on that standard simple test that have high LDL, but when they do an advanced test that really digs deeper into what this profile really looks like, turns out they're not at high risk. And then there are people on that simple test who are told, oh, everything's fine. And then they get the advanced test and we see something like lipoprotein little a skyrocketing high. I'm like, okay, no, everything's not fine. And so that standard test is simply not assessing risk the way it should. I would encourage everybody to do an advanced cholesterol test, which does look at those things, HDL, LDL, triglycerides, but it looks at other things like the lipoprotein little a. They look at the type of LDL you have. Is it large and buoyant, which is not as dangerous as small and dense? Right. It also looks at what are called apoproteins, like apoprotein B, which is the bad one, apoprotein A. But you get the point here. There's so many other things to look at that will help to really assess what your true risk is. Counting on that simple standard test, it just doesn't do a very good job.
And for all of you watching, I'm hoping you're taking notes, because what I always say to you is think of yourselves relative to your care of your own body. You are the contractor, and the doctors are people you hire to take care of your body. So all of you who built a house, you know how you run you're the contractor, how you run the cabinet maker and this. It's the more you know, the more you will be in control of your health, and the questions you can ask will blow your doctor away with, oh, you know that. So this is all really important information, Mike.
Yeah. I want to talk. So we talked about inflammation. That's chronic inflammation. And I'm glad we started there. We talked about sugar.
Right.
So obviously important to do things that help to bring down inflammation, important to do things that help control sugar. Specifically when you have too much sugar in your system, sugar doesn't just, it's kind of a bad guy. It does help make energy, which is important. But if you have too much floating around, it's active. It's highly reactive. It binds to things, and it's called glycation. And that reaction, when sugar starts binding to cells and cell surfaces, it damages that stuff. So sugar has a direct injury component to it against the endothelial cells that we talked about. So we got to keep sugar levels down. But there's a third thing I wanted to talk about, and that is visceral fat. There's basically two types of fat in the human body. There's what we call white fat, and then there's what we call brown fat, right? And another way of thinking it, white fat is your pinch and inch fat, the stuff you can see.
Right.
The brown fat is deeper. It's called visceral fat. And that's the fat that I always joke sometimes. In Texas, we call it the Dunlop disease. When your belly Dunlop over your belt buckle, that inner fat. And if you ever notice it, have you ever seen that classic 40, 50-year-old guy, right?
Yeah,
That's what we call the beer belly. You can go and knock on that belly. It's as tight as a drum.
Yeah.
And that's not because that's muscle. That's because that inner fat is pushing out his stomach and the skin's become taut like a drum. That's
right.
That type of fat, Suzanne. That type of fat worries me. That brown fat like that grows that big, that's inflammatory. It's cortisol based, and it is what drives high waist circumference, and all of that together is a recipe for a heart attack. So
how does somebody get rid of that brown fat? Yeah,
well, there's good news. Exercise is one of the simplest, easiest ways to burn.
Well,
thank God that it actually does respond well, right? It actually is. The harder fat to burn is the inch fat, right?
Yeah.
The muffin top. What do they call it? That's the hard part to get rid of.
We women all know that one.
Yeah. But, 3 to 4 times a week, 20 to 30 minutes at a good level, 75% your heart rate, you'll burn that visceral fat pretty quickly. And so many things improve. Once you start burning that brown fat, your inflammatory status gets better. Your sugar levels get better. Your stress levels get better, because that fat is just representing all of those bad things. And so exercise is key with that. You know what also works really well if you want some help with it, believe it or not? Seaweed.
Like seaweed capsules?
Seaweed, specifically brown seaweed capsules. They are fabulous at helping to stimulate burning of brown fat.
I'm looking at some seaweed right now. I guess I could go out into the ocean and gobble down.
Yes, you got a beautiful view right there. Yeah.
Beautiful. Yeah. Also with sugar, when you get your sugar under control, your cravings get under control too. And we have that great supplement called Dopa Renew that just totally, for me, takes away
that one, don't
cravings.
you?
And also to remember for everybody out there that sugar is cancer's happy meal. That's what I've always been surprised at. Oncologist's office, they'll have candy in the dish because people on chemotherapy are so weak. It's the worst thing you could eat, right?
Yeah, no, that just, cancer cells, they're becoming more and more immature cells. Cancer cells kind of degenerate, meaning they kind of go back to more of like when they were real young cells, and they just feed off that sugar, just like kids, right? Think of it that way.
I was just going to say, it sounds like little kids.
Just like kids. And so they run off almost more what we call anaerobic respiration. They don't need oxygen as much. They're just burning sugar.
Yeah.
So feeding them that sugar, you're playing right into who they are and how they act.
Right.
So big thing, cut out your sugar. Very important if you're on any kind of cancer treatment. Absolutely.
Right. Also, there's the brown fat, the visceral fat, and then there's bloating. And I hear from women, I recently was going through it myself. I finally have it under control. Bloating is an indicator that all is not well. Maybe you've got SIBO, small intestinal bacterial overgrowth, or maybe your microbiome, maybe you need probiotics. Maybe you got something else going on in there. So bloating is a language. I think the body talks to us all the time, don't you, Mike?
Yeah, no, that's designed that way, right? That's how you know something. That what the challenge is then for us to actually listen, right?
Yeah, the bloating is the body going, it's not good in here.
Yeah.
It's really not good in here.
Yeah. And most of us, and I think we've all been there, it's kind of like you don't want there to be a problem, right? We don't want to have to deal with a health issue. So a lot of us go around ignoring that language. We ignore those symptoms.
Yeah.
And of course, then there comes a point where now you have no choice but to face it because you're in the hospital with something, right?
Right.
So listen to your body. Absolutely. Bloating
that's the whole thing that you and I are big proponents of preventative. Now, preventative is a hard sell because when you're feeling good, you don't feel like doing anything preventative. But what we have adopted here in this country is we wait until we're in a catastrophic state.
Yes.
Then we climb uphill trying to find the answer. What about finding the answer long before you're in the catastrophic state?
Get ahead of the game.
Bloating is the body going, something's not right. Aches, pains, joints, not being able to digest, a shortness of breath, not sleeping. All these things is your body talking to you. More and more, everything you say, everything I read, everybody I talk to, the body is a system. You can't just look at one component of it. The whole thing works together. Like, it's the most magnificent machine ever conceived or ever will have been conceived.
Yeah. And to think that we, it wasn't that long ago in medicine where we treated everything as little individual organs.
Right.
And look at the specialties we have in conventional medicine. You got heart doctors, you got brain doctors, you got bone doctors, and they all get so hyper concentrated, right? In that one area that they forget that this system is within another system, within another system, within another, and it's all talking together. It's all interconnected through different, through nerves, through neurochemicals, all of that. And you have to look at the body as a whole, and you work down to the organ that has a problem. You don't start at the organ that has a problem and work up. That's the reverse. You start whole. And
what caused it?
You fix things level by level. Gut, energy, now thyroid. That's how
that makes sense.
Yeah.
One of the doctors I interviewed in my new book is Dr. Terry Hertog out of Belgium. I know you know him. What I often say this when I speak to doctors about the new model, where in Dr. Hertog's office, he's got the specialty for the heart, the specialty for the kidneys. He's got all these specialists that at the end of the day, they all turn it in to him. He's the alpha doc. Yeah. He looks at that person, everything every doctor said there, and then he's able to, like the detective, go, well, if that's happening, then that's because of this. Doesn't it make sense?
You have to put it together, right? Yeah. And for so long we've been practicing organ specific medicine.
Correct.
And you wonder, okay, is it really that hard to think? Well, yeah, of course we haven't made that much progress in a lot of things because we're not seeing it as a whole. And I'm convinced if I can just get more and more doctors to get their patients on the basics like CoQ10, we would make such a great impact.
Yeah, absolutely. Yeah. I have a friend who unfortunately passed last year, but he used to say to me, I have the best doctor for every part of my body. I said, yeah, but do any of them talk to one another? Nobody was talking to one another.
They don't.
So this guy's treating this and this guy's treating that.
Yeah.
Hey, you guys, I just want to hop in and say thanks for such a great show. So many people have said
we're done?
Almost. We've got people jumping in saying they're going to watch this again and take notes. Okay. I want to remind anyone, if you're looking for RestoreLife supplements, they're available at SuzanneSomers.com. Suzanne put everything at 30% off today. So the promo code is HEART30. It's a limited time offer. So we hope you can jump in and get the discount. And I'll let you sign us off. Thanks for joining us, Dr. Mike.
Oh,
well, thank you, Caroline and Mike. I always enjoy these. I enjoy your time. Yeah. You and I have a nice relationship.
Talk, that. We don't really, people need to know we don't have script. We don't review anything. We just start talking.
No, we talked about we didn't even talk about medicine before we came on the air, but it's always fun with you. I love to do this for all the people watching, and I know that they will watch the show over and over. This was jam-packed. So I thank you so much. And I can't wait till the next one.
All right. Thank you so much. Bye, everybody.
Bye. Bye, Dr. Mike.
Until next time.
Yes. Dr. Mike Smith.